Then we can invite Dr. Enrique Osorio to give his talk.
Thank you, Mehmet. Thank you, Salman and Dr. Rezaul for the kind invitation. I will share my screen. Okay. Mehmet, please habilitate my.
Yeah. I did it.
Okay. Okay. Okay, now it's okay. Okay. I will talk about the endoscopy in cervical disc. First of all, I want to invite all of you to attend to the 17th World Congress of Neurosurgery of the WFNS in Bogota, Colombia next year, August 29 to September 3. We have the inscriptions open. Please send your works for your abstracts, and please enter to the page of the Congress. This is our team: Dr. Ramirez here, Dr. Rugeles, Nicolás Prada, Gabriel Alonso, Carolina Ramirez, and myself. And the indications are for extruded not migrated disc herniations, foraminal stenosis, central lateral disc herniations. And the contraindications are anatomic anomalies, disc collapse, and instability or segmental deformity. And we have these approaches: anterior and posterior, and anterior not endoscopic or full endoscopic. I will talk about the full endoscopic. This is the position of the approaches are for axial pain, not endoscopic, and full endoscopic for radicular pain. The evolution is in 1995, was described by Dr. Choi, this percutaneous technique. And in this work, Dr. John Hsu, in 2000, he showed from 1994 and 2000, 200 patients with radicular pain secondary to the herniated disc, con a follow-up of 25 months, and with a 94.5 good and excellent results. And the patient returned to work 10 days post-op. And in 2004, the group of the San Jose showed a retrospective study in 111 consecutive patients, and with very good results, excellent results in 46.9, good in 33 patients, failing 9 in 80% of the patients, and poor in 11 patients, in 11% of the patients. And the major predictors of excellence long-term outcomes were irradiate arm pain and lateral hernia locations. And really, this is the best indications for endoscopy in cervical area. This is the technique. The patient, we put the patient in extension, neck extensions, and attraction the arms, and under local anesthesia. And here we mark the medial line, and here the sternocleidomastoid muscle. and perform an incision of 6 to 10 millimeters with blunt dissection and enter with the cannula until the anterior part of the disc. And perform a discography. And really, we put a blue colorate to differentiate the disc to the other structures. And then we put the dilators, and we put the working cannula. This is 2 of them. And we enter with that trephine to perforate the annulus of the disc to enter to the disc. And then we enter with the endoscope of 2.7 millimeters. And we use different instruments, grasper forceps, as you see here. In this case, we don't put indigo carmine, but in this case, we use the indigo carmine to differentiate better the disc to the other structures. And we use the radio frequency for coagulation and also for ablation, with a frequency of 1.7 megahertz and a potency of 25 watts. And this is from, this is the radio frequency. And use different instruments, of course. I want to present one of our cases. This is a very interesting case. This is a high performance white lifter. Guy of 26 years, and 12 months before, he has a right 7 radiculopathy, and with many medical treatments. And this is the pain. He described the pain in this area, and was in this moment when he suffered the herniation of the disc. And this is the MRI. You can see the herniation here at 6-C7. And we enter with the endoscope. We perform discectomy, C6-C7, right, under local anesthesia with sedation and outpatient procedure. And you can see here the procedure. And here is the fragments of the disc. This is the last fragment. This is the big fragment at the end. This guy, 3 weeks after surgery, he started his training voluntary. We say, please don't take a rest more time. But then in 2010, 2 years before, you can see the, and then we go to London and got the silver medal 2 years after surgery. And then next year in 2013, become a world champion of this area. And 4 years post-op, this is the MRI. You can see here, C6, C7. But in December 2015, 3 years after, become with lumbar pain radiate to the left buttock and leg, and also with the medical treatment. This is the pain referred by him, and here's the MRI with 2 herniation. This herniation in L4, L5, You can see an L5, LS1. And my colleague, Dr. Ramirez, operated this guy with endoscopy in L4, L5, and this is the, I can now show the video, but that this is the, okay, and this inicia the trainings with 360 pounds very early. And then 7 months after, he became a gold medal Olympic in the Olympics in Rio de Janeiro. Okay, we published this case last year, and our results with this technique in 38 patients from October 1997 to January 2019 with outpatient under local assisted anesthesia. We, with the McNabb All-Westry and BAA's an average follow-up of 10 years. And these are the results with McNabb. Follow-up is 90% with excellent and good results, poor results in 7 patients, and worse in 3 patients. With the All-Westry score, excellent and good in 63% improve in 30% of the patients, bad results in 6% of the patients, worse in 1%. With the BAS scale, pre-op in average 8 to 10 pre-op and 2 to 10 in post-op. The complications, initially we had 2 injury of the carotid and cervical hematoma in 3 cases, dysphonia in 3 cases. We publish in our results in this book of the World Federation Committee of the Spinal Committee of the WFNS, in this other publication of, we modified the blunt percutaneous approach to be more safe. And also in this book in 2018, with the Thermodiskoplasty, cervical discopathy and rhizolysis, and cervical endoscopic also. And what are the results in general? This is the randomized control study, include 120 patients with radiculopathy by Sebastian Rotin. And the sample was divided in 2 groups, 60 patients from anterior cervical discectomy mass fusion, and other 60 patients with anterior cervical endoscopy. The blood loss was not measurable on an endoscopy, and of course also was minimal with open surgery. Surgical time was significantly longer in open surgery, 62 minutes versus 32 minutes with endoscopic. There were not significant differences in improvement. In the endoscopic had advantage over the open surgery. In 2012, also we have this review that analyzed 11 studies. They found that the surgical treatment had a better outcome than medical treatment. The complications highlighted the possibility of the adjacent segments when using open discectomy. They did not find sufficient evidence to determine which method of surgical treatment is superior due to the quality and the heterogeneity of the studies. And this systematic review and meta-analysis in 2014 with 14 studies, including 4 cervical, they determined that the importance of the adequate selection and improved technique and special training for an adequate surgical result. The most relevant complication of the cervical minimal invasive technique was reoperation. There were no reports of serious complications such as death, infection, dural injury, or urotomy. There were no significant difference in the presentation of complications, and more high-quality research is required to define a recommendation. In this publication of Stefan Hellinger, we can see that we now have the possibility to do full endoscope bone fusion in cervical spine. The advantage of the endoscopic in this herniation in cervical area is we perform less soft tissue trauma, motion preservation procedure is not. Hello? Hello, hello. You can hear me?
Yes, we can.
Okay. And the non-adjacent segmented diseases, same-day discectomy procedure, and prompt recovery, and low cost. Also, excellent visualizations, less blood loss, less infection rate, prompt recovery, and revision surgery is accessible. And of course, the learning curve is longer, and you need the investment in the infrastructure initially. But in conclusion, we have similar results to open surgery with less risk. Best results in posterolateral disc herniations, and is contraindicated in myelopathy, segmental instability, and severe degenerative disease and anatomical abnormalities. And again, please come to Colombia next year. We hope that the pandemic will be controlled. At least all the physicians, all the neurosurgeons, we will vaccinate in the next first semester in the next year. Please come to Colombia from August 29 to September 3 of next year. Thank you very much.
Thank you, Enrique. Very, very nice, interesting lecture. And we are not, in fact, most spine surgeons are not very familiar with anterior cervical disc surgery with full endoscopy and under local anesthesia. Do you think, are you comfortable that the patient is awake at that time?
Yes, yes. Of course, we need a very good anesthesiologist for sedation. The sedation is very important. And normally, only in few cases, and also in the lumbar cases, we only in a few number of the patients, we need a general anesthesia. But we prefer local and sedation because it's the best functional or monitoring control. More than that, if you have a monitoring of the nerves and everything, but
Hello.
with local anesthesia, you can control these problems.
Yeah. Um, actually, what was your action? You mentioned that you had 2 carotid artery injury. You switched to open surgery?
Yes, of course, immediately. I have to open and then and close the hole in the carotid.
Did you have any injury to the root or spinal cord?
No, by fortune.
Yeah, fortunately. There are some questions from the audience. One, Dr. Uygur Er is asking, what is the reason that there is no adjacent segment disease? Is this method of surgery dependent situation?
No, with this method, we don't take out all the disc. We will go to the herniation and we will go to open the foramen and not to take out all the disc. And for that reason, I think the adjacent segment don't be compromised.
Yeah. Another question is that in your second case, you go anterior approach. Could you make it by a posterior approach?
Yes, of course. We can use anterior or posterior approach. Depends your expertise and your confidentiality with the procedure.
Yeah. You mean, do you also use endoscopy for posterior microforamen?
Yes. Yes, also.
Okay. What is the chance of kyphosis without fusion and instability?
But there is really we had not these cases in our series, and because we don't open, of course, previously kyphosis cases, and if you don't produce a great discectomy and instability in the procedure, you will not have this problem.
Okay. What do you do if accidental dural opening at a cervical root happens? What is your policy if the dura is opened?
Really, we don't have in these cases this problem, but in some lumbar cases, we don't do really nothing. And there are normally tears. The hole is very, very small and close without a problem. I remember only 2 cases of the lumbar cases, more than 1,300 cases. We had to open to take a open surgery to close.
But in fact, it is quite different in cervical anterior.
Yeah. But we had not these problems in cervical.
Because a good pseudo-meningocele or big mass on the back of esophagus. As you don't put cages, doesn't that affect the foramen height and causes foraminal stenosis?
No, because also we go to take out the herniation, but also to open the foramen when in the cases you have also hello.
Sorry, someone is open to the microphone.
Yeah. Some cases they have a osteophytes, and we go take out to take out also the osteophytes and open the foramen, and this is very, very important not only go to the herniation, but also to be sure that you open the foramen.
Very related with that, actually. Do you remove PLL, posterior long ligaments?
Excuse me, repeat me.
Do you remove during anterior discectomy? Do you remove posterior long ligaments?
Yes, yes. We use for that the open with the radio frequency, the ligament, the posterior ligament, and open the ligament in many cases when the all in the most in the cases with the stenosis of the foramen.
Yeah. Do you prefer this surgery mostly in soft discs instead of hard discs?
Yes, of course.
Yeah. You don't like to use drill very close to the root and very close to the spine cord. Am I right?
No, not exactly, because in this is not a problem to use the high speed drill, and but it's more easy, of course, to do this procedure in soft herniations.
Okay. Can you achieve bilateral uncectomy and or foraminotomy? The one interesting question.
Yes,
Bilateral.
in this case, yes, in these cases, I prefer to do posteriorly.
Okay. Yeah.
Posterior.
Dear friends, do you have any questions, Salman?
I think it's very impressive. I think results have been what the results we have seen is pretty good. I think we are not used to seeing this awake surgery for cervical spine, and it's interesting to see a different aspect of it. Very good. Very impressed.
Yes, me too. I enjoy that. Actually, I like to make anterior foraminotomies in many cervical disc surgeries, so that I don't use any cage, any disc. I don't do a real discectomy. Just remove the part of disc herniation. But this is very similar to that, but doing under local anesthesia. Very, very nice. I enjoyed it very much.